is Nargiza Saatova from the Uzbekistan. She is a very specialist in the hydrocephalus. So could you could you start your lecture, please?
Good morning, everyone. Good evening, good afternoon. Thank you so much for the introduction, and thank you so much, Dr. Manas, for your interesting talk. It's a very hot talk of discussion, especially ETV-CPC in infants. And I'm young neurosurgeon from Uzbekistan, right now doing my fellowship in Florida. Today, I will talk about the overdiagnosis of hydrocephalus and treatment thresholds. It's quite let's say, difficult topic came for me, but I will try to make it in 15 minutes in an easier way. So when we talk about overdiagnosis, we have to consider that whenever we take the patient for any extra test or investigation, it will cause the psychological stress or unnecessary treatment, which may not bring the outcomes we are seeking for. And hydrocephalus always come as a difficult topic when we come to the differential diagnosis, because the hydrocephalus can mimic as idiopathic intracranial hypertension, dementia with Lewy bodies, progressive supranuclear palsy, Alzheimer's disease, idiopathic intracranial hypertension. Visual changes, cognitive dysfunction, gait problems, and incontinence are the clinical symptoms which goes along with the patient whenever he comes to ED or whenever he comes to any normal polyclinic checkup. So when we talk about the hydrocephalus, we have to consider three important things: that there should be golden mean. We always misdiagnosis, overdiagnosis, and misdiagnosis. Especially, I'm talking from as a young neurosurgeon. So this is what we are facing. We are thinking that hydrocephalus is very easy to diagnose. Yes, when we look at the MRI or CT, but the mimic, when it comes to the different, let's say, symptoms, we are getting lost, and this is when the mistakes being started presenting. So what are the common mistakes leading to mis or overdiagnosis is the neglecting of proper clinical examination, superficial radiographic imaging investigation, neglecting of accurate differential diagnosis, and as a result, we are going for immediate invasive procedures like LP and unnecessary inserting of the VP shunt. I would give a few studies. So the first one is hydrocephalic Parkinsonism lessons from normal pressure hydrocephalus. So we know that hydrocephalus is an under-recognized presentation of progressive supranuclear palsy and dementia with Lewy bodies. So there is a study from Mayo Clinic, and they conducted the study from 1995 till 2003. So patients referred as a normal pressure hydrocephalus in amount of 411 referred to the Mayo Clinic, and out of that big number, we can see that only 41 patients was diagnosed with normal pressure hydrocephalus. Out of them, 14 patients were eventually diagnosed with this pathology only after going for LP and making that LP investigation. And out of these 14, 12 were inserted by VP shunt. And from that 12 patients, 6 patients by 1 year improved symptomatically, and only 4 patients improved symptomatically after 3 years. And out of these VP shunt inserted patients, 5 of them were having the presence of neurocognitive disorders, progressive supranuclear palsy, and dementia with Lewy bodies. So the results, despite of presence of ventriculomegaly, disproportionate to the extent of parenchymal atrophy, all patients demonstrated early postural impairment and or oculomotor abnormalities that encourage the diagnostic revision. hallucinations were the only early atypical manifestation of the hydrocephalic with Lewy bodies presentation. And in conclusion, they want to say that early postural impairment, false oculomotor impairment, and or hallucinations are inconsistent with the diagnosis of NPH, and it suggested that it might be supranuclear palsy or Lewy bodies dementia and lying under the normal pressure hypertension. So the next study is the study from our colleagues who are ophthalmologists, and they're talking about the overdiagnosis of idiopathic intracranial hypertension. So why I took this study, I just want to point that how many patients are getting misdiagnosed and overdiagnosed, and some of them are getting inserted with the shunt. So 165 were referred for pre-existing diagnosis of intracranial hypertension. Out of them, 86 with pre-existing were having actually that IIH, and 34 of them were not having intracranial hypertension. So from 34 patients who is misdiagnosed, 27 of them had at least one lumbar puncture, 29 of them had a brain MRI, and 8 of them had magnetic resonance and CT venogram. So 26 patients has received medical treatment already. So 1 had lumbar drain, and 4 patients underwent referred for the surgery. So it's quite big numbers, right? In 8 patients, an alternative diagnosis requiring further evaluation was identified. So the most common errors were inaccurate ophthalmologic examination in headache patients, thinking bias, reinforcing the need for the rapid access to specialists with experienced diagnosed optic nerve disorders, and in conclusion that diagnostic errors resulted in overdiagnosis of the intracranial hypertension in 39.5% of patients referred for presumed idiopathic intracranial hypertension and prompt unnecessarily test, invasive procedure, and misdiagnosis. So the high prevalence of primary benign headache and obesity of young women, we all know this often leads to the costly and invasive evolution of presumed intracranial hypertension. So another study, it is about normal pressure hydrocephalus following cranial radiation, identification of shunting responders. Also very interesting studies. So they took the patients who completed with radiotherapy at least 2 years before with clinically suspected normal pressure hydrocephalus, and Evans index was more than 0.3. So they were assessing cognitive outcomes, brain MRI, lumbar infusion test, and in the absence of any standard criteria for normal pressure hydrocephalus, a combination of clinical and neuroimagical features such as Evans index and disproportionately enlarged subarachnoid space are relevant to support the diagnosis. It is not something which is main, it's just supportive. But here they decided to make it as a potential predictive factors of shunt responsiveness. Presence of DASH, a positive test step, were considered as a supportive feature for VPS, but in this study, authors consider it as a predictive value. So it was found that when VPS patients are classified based on these features, they could identify VPS responders with a positive predictive value, which came out as a 78%, the negative predictive value 40%, and sensitivity of specificity is 70% and 50% respectively. So you can see that the study has shown that the addition of quantitative CSF MRI analysis in the study of patients with clinical suspicious post-RT normal pressure hydrocephalus could aid in identifying those who may benefit from VPS and those who is improving in clinical management and prognosis of long-term cancer survivors. The next study is the difference of in brain morphology between hydrocephalus, ex-vaco, and idiopathic normal pressure hydrocephalus. So in this study, they pointed that although CSF tap is an invasive procedure and lacks of sensitivity for diagnosis idiopathic NPH, it is effective in predicting shunt responses for patients with ventriculomegaly. So what is important right now, to going for less invasive investigations and focusing more on improving diagnostics through the non-invasive imaging between these diseases. So they took 9 radiological parameters where they compared index 7 decrease of callosal angle, narrowing of superior parietal sulci, height of the Sylvian fissure, width of the temporal horn, dilation of parahippocampal fissure, presence of focally enlarged cerebral sulci, severity of periventricular hyperintensities, and medial temporal lobe atrophy. And in conclusion, they found that the narrowing of callosal angle, dilatation of the Sylvian fissure, and the narrowing of superior parietal sulci may be used as a radiological key that indicates a non-invasive tool for differential diagnosis of the IMPH from hydrocephalus ex vivo. So here is the MRI, the example, which shows that the changing of angles. So if the angle is less than 40 callosal angle, so it indicates that the hydrocephalus is there. So I won't go too deep into this study because it shows too many classifications according to each and every cut. But these 3 important things which we have to consider in conclusion. Another study which I want to point in is the awareness, diagnosis, and management of idiopathic intracranial hypertension. Again, we are talking about hypertension, but I think we could put these targets in diagnosing the hydrocephalus as well, especially when it comes to hydrocephalus coming along with RT patients and along with neurological disorder patients. So improve the history taken, which should be addressed to us, young neurosurgeons and residents, the prepared questionnaires and proper diagnosis, education of doctors, especially in emergency room settings, in direct ophthalmoscopy. I think one of the problem when we lose the patients or when we get the misdiagnosis with the patient, it comes when patient is starting his evaluation from ED, just because the big amount of patients and you don't have time for proper diagnosis. That is a time when we can lose, and it is not just in hydrocephalus, but the patient who was coming with MI or with middle cerebral artery infarction, and the one who can simply go for STMC bypass, but they are getting lost because it's just getting treated by general practitioners, but not getting evaluated properly by neurosurgeons. And education of doctors in the accurate of LP procedure, which also goes up to young neurosurgeons and residents, establish cooperation with neuroradiological specialties. So general practitioner, optician, neurologist, ophthalmologist are the most important teamwork who is contributing in differential diagnosis of patients with any type of hydrocephalus, which is mimicking on the different diagnoses, let's say. And the teamwork, again, the neurologists, neurosurgeons, neurorehabilitation specialists, ophthalmologists, and pediatrician. So, thank you. Stop sharing.
Hey, thank you for a perfect lecture and a very interesting study, I guess. Thank you very much. And any questions?
Thank you very much for that excellent lecture, Dr. Saatova. When you talked about the normal pressure hydrocephalus, many patients who who fail the lumbar tap test, and some of them do.
Hello.
Sorry, can you hear me?
Yeah, now I can hear you. You said when they failed in tap test?
Yeah, when they fail tap test, when they have the shunt, they still improve. And there's a subset of patients. Do you think the problem is more underdiagnosis or overdiagnosis when it comes to normal pressure hydrocephalus?
In terms of invasiveness, I think it is overdiagnosis because I think the BP shunt can still wait in pediatric population, in adult population. So today I took mostly just adult population, the patients who are, whatever study I reviewed, the mean age was around 72, 75. Still, this patient doesn't need to be shunt inserted. And if we talk about the Alzheimer's disease or supranuclear palsy, so in one study they did post-mortem investigation of 4 patients, and all these 4 patients they were eventually having and confirmed with having supranuclear palsy, Lewy bodies dementia, and Alzheimer's disease. So maybe this is the right time when a patient comes with the clinical representation. We have to combine some neurology board or neurosurgery board, because I don't think as young neurosurgeons we will be able to immediately identify these. Yes, we see that they have imbalance in walking, they have cognitive dysfunction, but there is something lying under that, and it comes with experience. So somebody has to be who will explain us. And in terms of misdiagnosis, yes, but I think misdiagnostic also should, according to me, it comes also from a lack of experience, I would say, or overconfidence of neurosurgeon when he thinks that there is no need to go for ophthalmologist, but even ophthalmologists in their own field, they're facing the same problem, and some of them are already shunted. I mean, some of these patients.
Thanks. In the UK, what we often find is that patients with who have given a diagnosis of dementia or unsteadiness, they don't necessarily go and have MRI. They are not referred to MRI scans, and they are just then given diagnosis as vascular dementia or Alzheimer's dementia. So many patients go without having the scans to then decide whether they have got a known pressure or hydrocephalus or not. But I can also see what you are saying, that in the other side, when patients have scans and when they actually have large ventricles but different pathologies, then there's a higher risk of those patients having treatment that they don't need. So that's great. Thank you very much.
Thank you so much.
Can I ask a question?
Yes, sir.
What I understood is one tap test, if the patient has recovery, you don't go for a shunt.
Yes. In one of the studies, they were saying that if he has the recovery, so there is no need for going for shunt immediate. Oh, and you can do the always close follow-up observation, 1 month and 2 months. And
so when do you suggest shunt then?
When the clinical deterioration is when the clinical patient is not improving on follow-up, or if he is deteriorating, then it is the time for going for shunt. So, of course, it's individually all the time, but we have to consider that close radiological examination should be there, and correlation with clinical symptoms. So over here, more differential diagnosis was with neurological disorders, when the patient were, not the patient, but the clinical team was, in one study, they were more neglecting the reflexes, supranuclear palsy. So that disorder. So you see the gait disturbance, you see the incontinence, but you don't go to proper neurological examination to check whether maybe something also lying down behind that.
Yeah, what we follow is we do a repeat tap test, and if there is reproduction of recovery, then only we suggest shunt. We wait, first tap we don't do, but we wait for the patient to deteriorate, do a repeat test, and a repeat tap. If he can reproduce, then we suggest a shunt.
You do usually two tests, right?
Yes, yes.
You repeat it two times, yes. So when I was doing residency in Russia, we were following the patient by the same protocol. So now I don't work with adult patients, but yeah, we were doing the same thing.
I have a question on IIH. In the last slide on your algorithm, you had presented that if the patient has visual loss, then there is a need for a shunt for that patient. Immediate
If the patient has visual loss, yes. Just a second. So if the patient has, so it's the papilledema and the ophthalmoscopic test. So if it is confirmed that they have papilledema and vision loss, so they go for some of them offer the medical treatment, acetazolamide, but the VP shunt may also help them in that, let's say, clinical representation.
Means what we practice is a patient comes with papilledema, headache, and then has visual loss. We put a lumbar drain and for 3 to 5 days and start medical management, and then vision usually recovers with lumbar drain, and we continue medical management in those. So we could avoid doing a shunt for many of the patients this way, and preserve vision also.
So you go for close observation of vision improvement.
No, we do place a lumbar drain for 5 days.
Yeah, I understand.
And
after that, you're
yes, and continue medical management.
Okay.
Thank you, Dr. Manas. Dr. Panigrahi just to mention that in terms of diagnosing normal pressure hydrocephalus, it's one of those controversial areas with different centers doing different ways, and I certainly understand and appreciate the method of two lumbar tap tests that you do. And whereas there's been a number of publications where even when the lumbar tap test is negative, patients there are patients who improve with VP shunts. So, for example, if you look at the practice at Gothenburg, which is probably does the largest number of normal pressure hydrocephalus surgeries in Europe, they don't even do lumbar tap test. They look at the scan, they look for dash sign, and they have the neurologist who's leading the practice, and they make sure there's no neurological problem going on, and then they go ahead with the shunt and not doing any sort of adjunct CSF test. Only if there's any question, then they do it, but otherwise their standard is not even doing lumbar tap test. So sometimes what we find in UK is that we go through the lumbar tap test, but the problem is that the time it takes for the patient, we work in a government hospital, to come back, test, then to see the neurologist, by the time it's taking 6 to 9 months to a year, and the patient is deteriorating. So at the moment, there's no consensus, and I think each of us have the very good rationale for doing our practice, but just to so that people in the meeting appreciate that there's a variety of ways to diagnose, and certainly some of them will give overdiagnosis and some of them will give underdiagnosis. I don't think there's ever going to be a perfect test going to be there, but we try to improve the test to improve the accuracy. So thank you very much. Thank you very much again, Dr. Saatova. Shall I introduce Dr.